Hello, I'm Donna Cryer, founder and CEO of the Global Liver Institute and the host of Global Fatty Liver Day. I am so honored that our friends at the Association of Black Gastroenterologists and Hepatologists have decided to put together this extraordinary panel on healing your liver, what communities of faith need to know about liver disease. As you can appreciate, liver health information has to start with our communities, with our friends, with our families, with the person that we see every Sunday on the pew next to us. Certainly, that's how it started for me and my family before I needed a transplant for my liver disease. And we know that programs like Links for Life, that Links Incorporated created on organ donation and transplantation, can successfully share information and scale action across the country. We've seen successful community initiatives in hypertension shared through barbershops. We are excited to see what you do with the information that the Association of Black Gastroenterologists and Hepatologists shares with you. And so up next, I am happy to introduce Dr. Ratanya Carr, who is co-founder and board member of ABGH, and also associate professor of medicine and division head of gastroenterology at the University of Washington. Dr. Carr, I turn this over to you.
Thank you so much, Donna. I am thrilled to be here again representing ABGH. ABGH, as you know, is a 501c3 organization whose mission is to promote health equity in Black communities, advance science, and develop the careers of Black gastroenterologists, hepatologists, and scientists. Today, we are here to have a conversation about liver health, and it's targeted to communities of faith. We will specifically be talking about two liver diseases today: metabolic dysfunction-associated steatotic liver disease, or MASLD, which used to be called fatty liver disease, and also hepatitis C. And so we ensure to get this information out as far and as wide as possible. We will share this session on both the GLI and ABGH websites and social media platforms after this airs. Let's get started. You will hear today from several physicians and leadership in the faith community, and I am excited to introduce these panelists to you today. With me are Dr. Julius Wilder, who is a transplant hepatologist and associate professor at Duke School of Medicine. He is nationally recognized for his work in health disparities, health equity, and social drivers of health in gastroenterology and hepatology. He's the chair for Duke's Department of Medicine, Diversity, Equity, Inclusion, and Anti-Racism Committee, and vice chief of Diversity, Equity, and Inclusion for the Duke Division of Gastroenterology. Dr. Ashley Spann is a transplant hepatologist and assistant professor at Vanderbilt University School of Medicine. She's a clinical informaticist and physician scientist. She's the director of the Clinical Research Informatics program for the Gastroenterology Division, and she is nationally recognized for her research on methodologies and best practices for leveraging informatics techniques and artificial intelligence for the management of patients with chronic liver diseases. With her research, we have really advanced what we know about using these methods to improve equitable care delivery. Dr. Lorna Dove is a professor of medicine and the director of liver transplant at Columbia University Medical Center in New York. After training in gastroenterology and hepatology in San Francisco, she joined the New York Presbyterian transplant team in 2001. Her clinical and research interests include liver transplant outcomes, viral hepatitis in patients with HIV, and improvement in care systems for those underserved by the medical system. Dr. Dove is a member of the Association of Black Gastroenterologists and Hepatologists and the Black Liver Health Initiative, who is co-sponsoring this event. And finally, but certainly not least, we have Reverend Dr. Orlando Dowdy, who is the presiding elder of the Sanford District, Central North Carolina Conference, Eastern North Carolina Episcopal District. He is the former pastor of the Holland Chapel AME Zion Church, where he served as their pastoral leader for 11 years. He has served as adjunct professor at the Mount Olive College for 4 years, where he taught undergraduates the Old and New Testaments and ethics. He is an executive committee member of the Duke AME Zion Initiative in Clinical Research, is a member of the Duke Clinical and Translational Science Institute, Community Engagement Core Community Advisory Council, and participates in patient-centered outcomes research. Welcome to all of you. We're going to get started, and I think I would like to start this conversation with you, Dr. Wilder. You are a transplant hepatologist, and you recently partnered with the AME Zion Faith community to get the word out about liver health. Now, we're going to talk about some specific liver diseases today, hepatitis C and liver disease resulting from a problem with metabolism. But I'm wondering, before we get into those specifics, if you can share briefly with our audience, what exactly is the liver and why is it important for us to care for our liver? These are probably the two most common questions that we hear.
Yeah, thank you so much for that wonderful introduction. And I think, like my colleagues, very happy to be here. The liver, by far, is my favorite organ. I think it's amazing. It's located actually on the right upper part of your abdomen, right beneath your rib cage. And it is a vital organ that really has a significant impact on a number of functions. It helps with respect to how you digest food. It helps detoxify things in your bloodstream. It's important when it comes to your body's ability to make hormones, proteins, carbohydrates, managing fat. It helps you fight infection. It's really, really important when it comes to things like diabetes because of the role it plays with respect to controlling your blood sugars. And it also plays a vital role in storing your energy. And so as we kind of go through our conversation today, you'll see how, as we talk about these diseases and the liver, how important it is and how it affects so many different systems in the body.
Well, thank you for that introduction. Now, hopefully everyone listening knows exactly where their liver is, can point to it. When there's a problem with the liver, does it always cause pain?
So that's the thing. It's an organ that can tolerate actually a lot. And what that means is that you can have an underlying issue with your liver, not feel pain, not be aware of it. And so unfortunately, it's not uncommon for us to meet people who have liver disease, that unfortunately were unaware of it until it got pretty severe. You just don't really feel it all the time when something's happening with your liver.
So if your liver doesn't hurt when there's a problem, how is it even possible to get a checkup of the liver?
And this is where one of those situations where one's ability to engage regular healthcare becomes really, really important. The most reliable way to assess and ensure your liver is okay is to minimally have some blood work done once a year. Typically, this is done with your primary care physician, and they check some blood work. And those tests include what we call liver tests that provide insight around how well your liver is functioning, can also let us know if there's any concern in terms of inflammation in the liver. It is then that we can make sure your liver is okay.
Well, you're a liver transplant doctor, so clearly many people haven't been getting that kind of general liver care over time. You must be fed up with people needing your help when many diseases, a couple of which we're going to talk about today, are preventable.
You're absolutely right. I think the thing that's probably the most frustrating for us as liver doctors is that, again, you often see people who've had an underlying liver disease, for example, hepatitis C for decades, unaware of it. And now they're presenting to us because now it's progressed to where they have what we call maybe end-stage liver disease, liver failure, and other really significant complications. And that's why it's so important we're having this conversation today. And it's so important that people have regular conversations, with their doctors about their liver health.
So what are you doing locally? Part of why we're here today is to get the word out through this webinar, for example. But I'd love to hear in North Carolina at Duke, what are you doing to get the word out about liver health? And specifically, if you can talk about how you're partnering with the local faith community to make sure that these stories of people having delays in care and then needing your help as a transplant hepatologist become less common.
Yeah, liver disease is quite prominent in all communities and one of the leading causes of death worldwide. And particularly if you look at communities of color, we see a disproportionate burden of liver disease. There are lots of health disparities that exist in that space. And so when we think about how we can better educate communities, generally speaking, especially communities of color, we identified a really, really key partner in our space here in North Carolina that we found to be such a wonderful partner to work with in many other spaces in medicine, healthcare, and research. And that is the AME Zion Heal Group. And we're lucky to have one of their leaders here with us today as part of this conversation. But this is a very unique group of pastors that have been trained in science and clinical research and community engagement. They are able to provide us insight and guidance on best ways to engage the general community and especially their faith communities around health issues. And they are really key partners on a number of grants, including some of my own, where they've worked with us to help us develop projects, initiatives, policies, and do research to improve health outcomes, generally speaking, but also to help in terms of specifically liver health in communities of color, particularly in the faith community here in North Carolina.
So, Dr. Wilder, your initiative is called AME Zion Heal. And is that like healing hands? What does HEAL stand for?
Oh, yeah, it's the AME Zion Health Equity Advocates and Liaisons. And it's a partnership between Duke and this incredible group of pastors who represent a number of churches and millions of parishioners of those churches across North Carolina. But of course, that's a group that goes even more broader in terms of Southeastern United States and actually nationally as well.
That's really fantastic. And I really want to hear more about this. And Reverend Dr. Dowdy, you are another expert with this program. You're a member of AME Zion Heal. Thank you so much for coming to join us today. I know that we are just so privileged to have you here. And, because we're also reaching out to other faith community members with this program, I thought it'd be important to talk a bit more about AME Zion Heal. And so from your perspective, why was there even a need for AME Zion Heal?
Sure. Well, it's good to be here. Well, one of the big things is how to reach the communities. How do you reach African American communities to have them more engaged in clinical research, as well as understanding some of the problems that plague our communities and how they can have better care and how we can close the gap with health equities and disparities.
And what do you think in general has been the impact of this program?
Oh, I think it's been tremendous. We've done some work with North Carolina Central. We've done some ethno dramas, which are pretty entertaining, but also very informative. We did a lot with when COVID-19 hit. We did a lot with faith in the communities and understanding COVID and what COVID is, what it is not, helping people to engage that, talking about diabetes and hypertension, looking at those type things and, heart problems, reaching the communities because one, they trust us. This has been a process, but it's been very effective and it's really gotten our people engaged more.
So take me back a little bit when, I've known Dr. Wilder for a very long time. We won't say how long because that'll speak more about my age than his. So he came to you with this idea. Can you remember like what you were initially thinking? Was this something you were maybe not even initially on board? Did you think you weren't even qualified to help him with this idea?
Well, actually, we've been doing this, I think, around 7 years now. Sure, we had apprehension. I didn't know what it was about. I mean, Yale had started this in clinical trials, and then there was some AME Zion connections there. And so they came down to North Carolina, presented, and we, along with Duke, said, yeah, let's do this. Let's partner. Let's make this work, because we saw the value in partnering around health. Now, did I come with some hesitation and questions? Of course. I think most of us did, because when we start talking about clinical research and we start talking about engaging with health communities, we remember some of the atrocities that have happened with experimenting on people of color, minorities. They even include the Nazis, some of the experiments they did back in World War II, but truly, Tuskegee and with Henrietta Lacks and some others. And so we had to get through our own questions and our own doubts. But really, the training, the hours that we spent was very helpful for us to see that there have been some things put in place. You know, you have the IRB boards and you have, all other kinds of mechanisms in place to try to keep those things that are unethical, those practices, from affecting people who come in for help.
I really love. The more I hear about it, the more excited I am about this, and really look forward to opportunities to have this in other areas of our country. I'm going to bring this back to you, Dr. Wilder. Well, I'll just say it bluntly. I keep hearing that Black people, we are not interested in our health. We don't trust medicine. It's too hard to get us involved in research studies. What are your thoughts about these messages?
Yeah. I mean, quite frankly, a lot of those messages are just unethical, and grounded in bias and a propensity to want to blame the victim because it makes it easier to not fix the problem. But I think we all know that's not true. That having been said, there is some appropriate, as Dr. Dowdy just mentioned, hesitancy and concern that communities of color, particularly Black communities, have about engaging in clinical research because of what's happened in the past. But that having been said, we're not a monolithic people, like no one is. And when they actually look at the research on engaging populations, particularly Black populations, the biggest barrier isn't the sort of assumption, isn't the issue of us trusting or having distrust with research. The biggest barrier is actually researchers assuming that we don't trust them enough to participate. And so when you implement things around just asking, which actually is what a study that's been done, just asking engaging communities of color to see if they'd be interested in clinical research, and then providing the health literacy and knowledge and being transparent about it, you actually get pretty good buy-in from communities of color. And so, while we have a good reason, legitimate reasons to be concerned about clinical trials and clinical research and engaging in this kind of work, the data would say that as researchers, the biggest barrier is us actually having those conversations. And as we develop protocols and studies, that we are appropriately engaging communities of color, which speaks to why AME Zion is so important, because they help us develop those protocols. They help us, think about the best ways to do them to ensure engagement from communities of color, and the best ways to bring it to them, so that we can, do our best in terms of getting their engagement to participate.
Yeah, that makes a lot of sense. And thank you for sharing that perspective with all of us. Reverend Dr. Dowdy, how do you think we can scale what you all are doing in North Carolina, and I understand now at Yale, to other areas of the country? How do you think we can all take part?
Well, we've done a lot of work. I mean, a lot of work, lots of hours have been put into developing a playbook, how you can duplicate what we have done into other areas of the country. Granted, like with us, geography is different for us than it is up in Connecticut. They're more compact and we're a lot more spread out down here. And so there's some differences, also in the institutions and the hospitals that may be involved. However, you can take that playbook and we have a Facebook page, lots of information on it, and take it anywhere in the country and you can make it work. You can make it happen. The hours of training, what we trained in, all of the studies that we have participated in, with the researchers, and also going out into the communities. This is not something that happens inside, let's say, the walls of Duke or inside some institution. We go out into the communities and they come to us. The researchers come to us and they do their studies and their presentations. And it has really helped tremendously for our people to have a better understanding and seeing the need to be involved and how it can help them. And if it can't help them, it may be able to help, their children or grandchildren. And so they're bought in. There's a tremendous buy. I mean, the Duke group that we work with, they're tremendous. I mean, tremendous. And so my hat goes off to them as well.
That's awesome. It's nice to know there's almost a playbook, which I hadn't realized that exists. So Well, that's important information, and we're here to talk about all things liver health today. Thank you so much, Dr. Wilder and Reverend Dr. Dowdy, for sharing how you do it in North Carolina and how the medical community and faith community can partner to improve the overall health of communities. I'm now going to segue into some of the details of 2 liver diseases we want to make sure we cover today to make sure that at least for these 2 preventable and treatable liver diseases, we provide the most up-to-date information for those of you watching. Dr. Span, I'm going to bring you in now. First, thank you for joining us and congratulations on the birth of your new baby. Really excited to hear about that journey in your life. Dr. Span is another transplant hepatologist, and she is going to help us understand the liver disease that is the focus of what is now called Global Fatty Liver Day. First, what is fatty liver and what do we call it now?
Absolutely. So thank you so much for having me here today. So previously, fatty liver was in reference to something called non-alcoholic fatty liver disease, or NAFLD. However, this has been since changed to metabolic dysfunction associated steatotic liver disease. It's a mouthful, but it's very important that we've made this change, and it was necessary for us to do this. This came about as a result of a multi-year, multi-society evaluation of the actual name itself. And we wanted to make sure that we reduced any stigma associated with terms like alcohol, terms like fatty as well. And we really wanted to focus on what the actual biology of the disease itself was.
So this new name, I can attest in my own liver clinic, is hard sometimes for people to remember, but I know that over time people will get used to it, just like they got used to the old name. But how do you explain this to your patients in clinic?
Absolutely. So I always tell my patients that with liver disease, it can be caused by many things. In this case, it's a result of something called steatosis, which just means there's excess fat within the liver. In particular, this condition is a result of that excess fat, as well as the body's response to it and its overall effect on the metabolism. So the body recognizes the fat within the liver as an unwanted guest. And as with any unwanted guest, your body's going to want to get rid of it. In this case, that results in inflammation in the liver. And if that inflammation persists over time, that can potentially lead to scarring. And if that scarring persists and stays there, and with prolonged exposure, it can lead to things like advanced scarring, end-stage liver disease, or cirrhosis.
And what is cirrhosis? What does that mean?
Yeah, so cirrhosis means that you have significant scarring throughout the entire part of the liver that is preventing it from being able to regenerate and can lead to complications of liver disease that can also lead to meeting people like myself and Dr. Wilder and Dr. Dove and you as well, Dr. Carr, for indications of things like liver transplantation.
So it sounds like MASLD is a disease, just with the term metabolic in its name, that it's a disease that doesn't only affect the liver. It's kind of like, is it like diabetes where it has effects throughout the body?
Absolutely. And we think about patients who have this condition as being a condition where their metabolism is gone awry. It's working abnormally in the body. So we know that patients with obesity, those who have diabetes, those who are even considered to be pre-diabetic are certainly at risk for this as well. If you have high cholesterol, high blood pressure, all those things put you at risk for this. There are also some genetic things that can contribute to this as well, but it's also important to know that having a family history of this condition also certainly puts you at risk for this too. And this condition is incredibly common, but it's also very unrecognized. And more often than not, as Dr. Wilder mentioned earlier, patients don't have symptoms of this at all. So we have to really be mindful of that as we're moving forward and thinking about how we take care of these patients.
So you mentioned it's common. How common is it?
It's very common. The disease itself knows no limitations whatsoever. It affects people of all ages, races, genders. Literally everybody could be potentially affected by this. Across the world, it's approximately about 1 in 3 adults and even in 1 in 10 children.
I'm sorry, kids can get it too?
They can. Sadly, they can. And this is something that we are just becoming more aware of, and we need more particular work and to be done in our pediatric populations to truly understand how this is going to affect these patients as they move forward in their lives. But certainly our children are certainly at risk of this as well.
And we're here with programming for ABGH. Can Black people get MASLD?
Yeah, so the most common population that's affected by this is the Hispanic population. However, Black people can definitely get masled. And despite this, I would say the suspected prevalence of this disease among Black patients is not really well studied. And unfortunately, anecdotally, we are not seeing many Black patients in our clinics with this, let alone even in clinical trials for medications to target this disease, and even for transplantation in those who have advanced disease and complications from this particular condition. Doesn't mean that these patients don't exist, but we're having difficulty capturing them in our communities.
Why do you think we're not seeing them, and where are they?
I think there are a lot of things that are kind of at play here as to why we're not seeing the true prevalence of MASLD in Black patients. As I mentioned before, there's limited awareness of this condition, both by patients and providers. It's often missed. It may be misdiagnosed as another liver disease condition. There may be limited access to healthcare in general that prevents people from being diagnosed in the first place. Studies have even shown that regardless of race, people who have finding of this on imaging studies and don't know about it. Less than 2% of patients who had this didn't even know that it existed on their imaging studies. In understanding some of this, some of the work that I've done myself has been trying to use AI to kind of capture those patients who were just missing. And in some of the work that I've done, we've seen that in patients who have this finding on imaging, those patients who are Black, those patients who are women, and those patients who are older were much less likely to have a documented diagnosis of it, even though they truly had the condition. And it's things like that. If it's not documented, it doesn't exist. So we need to make sure that we're doing the work on being able to better capture these patients more globally so we can truly understand what it means for our specific population.
Now, you mentioned AI. I know that a lot of people these days know what that means, but can you just briefly explain what that is, what type of research you do in this area?
Yeah, absolutely. So what I like to focus on doing is using the data that we have existing on our patients in their electronic health records, in their medical charts, and being able to pull out of that, things that tell me that this person may have a specific disease. In this case, what I've done is look at all of the data, all of the text that is within radiology reports and clinical notes, and using an algorithm to extract that out. So I can truly say that if this exists, I can find it. And if I can find it, then I can treat it. And that's kind of the focus of how we utilize the algorithms and the AI tools to be able to detect these findings.
So you mentioned treating it. Is this is MASLD a reversible or a treatable condition?
So absolutely. In general, whenever the liver experiences damage, it can regenerate. However, that's dependent on two things. The first being you need to be able to identify what's causing the damage and stop it. And then you need to be able to stop it in the first place. And the way that we think about this is that this disease is caused by excess fat within the liver. So if we can do anything that gets rid of that excess fat, that is going to help the liver regenerate and improve. So that can include things like making sure that we find these people early on in the process so that we can stop and promote the reversal of this condition. We need to think about things around targeted weight loss, whether that is with a self-directed weight loss program or even structured weight loss programs, dietary adjustments. You can think about surgical weight loss or bariatric surgery, even medical therapies for weight loss, such as Ozempic or Wegovy, or even now we have a newer medication that was just FDA approved for this condition specifically that looks at patients and treats patients who have evidence of this disease as well as any scarring in the liver.
That's exciting. There's a new medication for this condition. Can you talk about that a little bit?
Yeah, absolutely. So this medication is called Resdifra, and it's specifically for patients who have evidence of scarring within their liver related to steatotic liver disease. In this case, the way that you might want to find out if you might even be a candidate for this is to certainly talk with your liver doctor about this. They may perform a test to determine how much scarring you might have in your liver, if any at all. And that could be something called a FibroScan or even a specialized scan like an ultrasound or an MRI study. And based on those results, that'll help the liver doctor decide if you qualify for therapy. And if you do, they can monitor you while you're on therapy. And they may try to combine it with some of these other possibilities of other medical ways to reduce your exposure to excess fat in your liver.
So I'm hearing talk to your doctor and talk to a liver doctor, because right now it's a new medication and many primary care doctors may not even be familiar with it. Would you agree?
I would. And I think it's something that we're continuing to work in close continuity with our primary care providers. We need to do more within that space, because that's where the majority of these patients are being seen before they make it to us in the liver world. So we need to do some more kind of coordinated efforts with our primary care providers to educate them about this medication and when it might be useful for their patients, and making sure that we have kind of a good way to ensure that we're capturing those who might benefit from this.
I'm very encouraged by everything that you've said, Dr. Span, because I have so many patients in my clinic, as you've said, who come to my clinic having been diagnosed years prior with extra fat in their liver and being told there's nothing that anyone could do about it, or it's nothing to worry about. And then they have progression by the time that they see me. But what I'm hearing you saying is that MASLD is a treatable and reversible liver disease, and there are lots of options for treatment. And the key is really to be informed and to advocate for what you need, because not every doctor might even be up to date on all the things. And so that's really encouraging. And what I want to talk about a little bit too is prevention of MASLD in the first place. Can you talk about how we can prevent getting it in the first place?
Absolutely. So we definitely need to start thinking about this disease the same way that we do about heart disease. This is not something that's not only treatable, but it's also preventable. So just like there's a heart healthy diet, you need to think about it as a liver healthy diet, where you have little or less exposure to excess calories, and no to very minimal exposure to alcohol as well. Maintaining a healthy weight is very important, as well with regular exercise, and that is also can be very beneficial. So I think making sure that we start shifting our thinking about this and focus on how can we do things to prevent this disease in the first place is going to be incredibly important to kind of limiting the effects of this disease overall in our population. It's also very important to know that if you have a family history of this, as well as any other liver disease that can tell you what your overall level of risk is, it's important to, one, know that, and to two, also make sure your healthcare providers are aware of that as well.
It's this issue of family history keeps coming up, and you're absolutely right. This is one of those diseases which we're now understanding does run in families. So knowing your family history is super important. All of this is really great news, Dr. Span. And, we now know that we can prevent one of the most common liver diseases just with how we live our daily lives. I'm going to bring Dr. Wilder back in now because I want to talk about another preventable and treatable liver disease, hepatitis C. Dr. Wilder, what is hepatitis C?
Sure. Hepatitis C is essentially a virus or an infection. And you can get viruses in different parts of your body. We're all very familiar, for example, with the recent pandemic and what COVID was. But hepatitis C is a virus that affects your liver. It lives in your liver, and it attacks your liver and causes significant inflammation in there. There are a number of ways that it can be sort of spread from person to person. The most common ways, including some kind of exposure to blood. In the past, it may have been blood transfusions. More commonly, we see it in the form of like IV drug use, for example. But really, it's a blood-borne virus that primarily attacks your liver. It sits in that liver cell, causing inflammation and damage over time.
And I did hear you talk about injection drug use, and that's not the only way that people can get it. Sometimes people say, well, I never did that, and they think they're not at risk. But you also mentioned blood transfusions. Are there other ways that people sometimes come to you who've been exposed to this virus unknowingly?
Oh, absolutely. I mean, there are, it's also a virus that can be spread through sexual contact. We have patients who have not necessarily even IV drugs, but you've seen cocaine use. Any kind of exposure to blood that you may have had in the past, that is a way that you could have been unfortunately exposed to it. It is a virus that has had a disproportionate impact on communities of color historically. More recently, we see it more common actually in a lot of white populations, particularly younger populations and Native American populations. But historically, if you look at the overall burden of hepatitis C in the United States, you'll see that, as you can see here on the slide, Black folks are more significantly impacted by hepatitis C. And here we're looking at just overall, how common it is in these different populations. Unfortunately, this is also the case when it comes to who's dying from hepatitis C, and that is killing more Black folks as well as Native Americans in the United States today. And then to the right here, we wanted to highlight that it is sort of something that's across multiple generations. Meaning, if you look at millennials, Gen X, the baby boomers, you still see a significant burden of it. But there's been this sort of interesting bimodal distribution of it, where you see it popping high in the millennials. Again, that's often attributed to what we've seen in terms of IV drug use, whereas in our baby boomers, and also often the case with a lot of our Black population, more unknown exposures, probably exposures from like just unclean needles in the healthcare, or unknown blood exposure, those kinds of things in the past, driving what we see in terms of the baby boomers. I will say, the thing about hepatitis C is that it is a virus that we actually do have a very, very good cure for. In fact, we are at a point in time now where the president is working on a hepatitis C eradication plan because the medications we have right now work so well. They can absolutely cure you at rates greater than 95%. And therefore, we are able, because we have good tests for hepatitis C, to identify if you have it, and then provide you great treatment to cure you if that's the case.
Well, that's good news too. I mean, today is just full of good news. Dr. Wilder, you'll have to update us. I remember, at least being taught, I don't know how prevalent it is, that even contaminated blood from getting tattoos in tattoo parlors, is that still one of the known risk factors, or not so much anymore?
Oh, absolutely. It's a known risk factor. And in fact, within the prison population, one of the more likely causes of such prominent hepatitis C is the use of needles for tattooing that, are used from person to person. Therefore, you're kind of spreading through that contact, through the blood contact from those needles. And we do consider, having tattoos, when talking to people about hepatitis C, that is a potential etiology, for how you got it. And so, it sort of comes back to the idea of trying to ensure that and again, hepatitis C, almost similar to some of the things we talked about today, in liver disease in general, you may not even be aware that you have it. And so that's why it's so important to be careful about, sharing needles and those kinds of things, because of those risks.
So if you get it and, it can be silent, you don't know that you have it, how do you find out if you have it?
Yeah. Well, really, every person in the United States that's 18 years and older should at least have one screen for hepatitis C. And so if you've not been screened yet for hepatitis C, please talk to your primary care doctor and be screened immediately. We actually recommend more frequent screening if you're an individual doing anything that might be exposing you to blood or needles or any kind of risk factors that increase your risk of hepatitis C. Now, the key thing here is that if you do get screened for hepatitis C and the test is positive, it's important that you are referred to a liver doctor as a next step for ongoing treatment and management. And I'll actually take a pause here, because I really think it's important that our population, particularly the Black population, understand that, yes, your primary care doctor is important for a lot of these screening things, but if they find something, it's important that you get referred and seen by a specialist who can then help navigate and address whatever underlying liver-specific issues that you have. And so in this case, if you are found to have a positive hepatitis C virus test, you absolutely should be referred to a liver doctor who can then do more tests to understand and better contextualize your hepatitis C and how well your liver is doing, and then provide you appropriate treatment.
So I'm hanging on the word treatment. Are you telling me that in 2024, no one has to die from hepatitis C, that they don't have to progress to the point of needing a liver transplant because of hepatitis C? Is there a cure for this? And what does that look like?
Yeah, no, it's absolutely a cure. If a person contracts hepatitis C today, if they die from that disease, that's just a failure on our part. The medications are exceptionally good medications that work very, very well. They're very well tolerated with very, very few side effects, minimal drug-drug interactions. And you're talking about taking a pill, maybe 1 or 2 pills a day in the range of 2 to 3 months. And we're talking about cure rates 95, 99% above. And so we absolutely have a cure. And it's because of how well we can screen for it and identify it and treat it that our President of the United States has put forward a plan actually now to actually leverage resources to definitively eradicate hepatitis C. That because the medications work so well and we can so easily test for it now, that we are at a point in time where no one should be dying from this disease. Absolutely.
Yeah, yet there are people dying from this disease. So a lot of work to do. I know that, some of our professional organizations like the American Association for the Study of Liver Diseases and patient advocacy organizations like GLI and American Liver Foundation are working to help get the word out. But programs like this are super important because, not everyone is on these websites or listening to government channels about the programs that are coming down the pike. So thank you for sharing that. Not only is this a disease that has a test, it's just a blood test, right? It's one of the easiest things, but also it has a cure. And just say again how quickly that cure can be achieved.
Yeah, I mean, we're talking about within months, once we initially get you in clinic and begin that process. And it's a simple pill that you're taking. And so it's, I think in the past, some people might be scared because it was a much more complicated treatment. It didn't work very well. But right now, today, we have great tests to identify you and really fantastic treatments to absolutely cure you in just a few months.
Yeah. And can you just say again, in case people missed it in the early part of our conversation, what is the recommendation for testing? Like, what is your ask of everyone watching today?
Yeah, I can't emphasize this enough. If you are 18 years or older, you should first of all have a conversation with your primary care doctor to ensure that at some point in time they have checked you for hepatitis C. If they have not, you should be checked for hepatitis C right now, because it's certainly possible that you have hepatitis C and you don't know it. And in that setting, if you are found to be positive for hepatitis C, again, I want to emphasize the importance of you then seeing a liver specialist, because then we can provide you proper care in terms of understanding the burden, in terms of how much damage has been done to your liver, and in making the best sort of decisions in terms of the best way to treat you.
Thank you so much, Dr. Wilder. What an amazing amount of information and very encouraging, hopefully, for all of those who are watching. I'm going to segue now to Dr. Dove because, Dr. Dove, you're in charge of the transplant enterprise where you work. And I imagine you see a number of patients who need your help. And they might not have needed your help if they had only had someone diagnose their disease earlier or treated their disease earlier. And now they're needing a liver transplant. And so before we get into all of those questions, what is a liver transplant?
Great. So first off, let me say thank you for inviting me to be a part of this. As a lifelong AME Zion member, I've always seen it as a place of education. So I think that this forum is really just fantastic. A liver transplant is really just what it says. Your liver is taken out because of some reason. It is too sick. It is not able to do the things that it needs to do for you. It's not filtering. It's not making proteins. It's not helping you fight infections. And it's a crucial organ. And so when we have exhausted all other ways to treat you medically and your liver is failing, oftentimes the best treatment, the rescue treatment, is to take that liver out and put a new liver in. And that new liver can come from a donor who is deceased and was gracious enough to leave their liver, or it can come from a living donor, of a family or friend, someone who is able and also very gracious to give you part of their liver. And as mentioned before, the liver has this amazing ability to regenerate and to grow. So even half a liver becomes a whole liver. So they put the liver right back in that right side under your diaphragm where you saw in that first picture. It starts working even before you leave the operating room. And then over the next few weeks, as you heal, it takes over all of the functions that your old liver wasn't doing. So a liver transplant is life-saving for people who have end-stage liver disease or a liver that doesn't work. But it's also sometimes used for people who have liver cancer as a cancer treatment. Even if the liver is working, if the only way to cure you is to replace the liver, it's an option there as well.
So I want you to talk a little bit more about the different kinds of transplant, and specifically, because we have people watching who may have never heard that you can give part of your liver to someone. Most people have heard about kidney transplant and giving one of your kidneys probably, but maybe not so much the liver. And so for the person who donates half of their liver, do they live the rest of their life with only half a liver?
No, they live their rest of their life with a liver that looks a little bit different, but is just as big as their liver was in the beginning because it grows back. In fact, within the first 3 months, it's about 80% back to its normal size. The liver, me like that, Dr. Wild and I, is my favorite organ. It's pretty incredible. And the fact that it can grow back is one of the reasons I find it amazing. And so you are correct. People always think about donating a kidney because you have two. You don't have a spare liver, but your liver is divided into a right side and a left side. And so the surgeons, if safe for the donor and enough liver for a recipient, can divide a liver and give you a part of that liver and let them both grow back to normal size.
Thank you for explaining that. You are at one of the premier institutions in the country, and we've been talking earlier about two liver diseases that are very common, MASLD and hepatitis C. And neither Dr. Span nor Dr. Wilder said that they, tend to see a lot of these patients who are Black in their practices, perhaps for a number of reasons. But I'm wondering if one of the reasons is because they're seeing you for liver transplantation. So are you seeing a disproportionate number of Black patients being transplanted for MASLD or for hepatitis C?
So that's a complex question. And so maybe I'll answer it with some numbers. So in 2023, we did the largest number of transplants, liver transplants that had ever been done in a single year. There were 10,000 liver transplants done. And 10 years ago, the number one reason for transplant would have been hepatitis C. But because we've made so many efforts with treatment of hepatitis C, identifying hepatitis C, preventing hepatitis C, that has dropped dramatically, and MASLD, fatty liver, has grown. It is not the number one reason for transplant. Alcohol still remains the number one reason for transplant. But even though fatty liver has become the second most common cause of liver transplant, the doors are not breaking down with African Americans. Of that 10,000 people, only 7% approximately of patients receiving transplants in 2023 anyway were African American. So though that clearly is below the 12.5% of the population, and though it is true that African Americans don't have MASLD at the same rate as, let's say, our Latino patients, probably there's definitely an underestimation of African Americans on the transplant list and receiving transplant. And there are multiple places, multiple reasons why that can occur. The path from being identified as someone who has liver disease to actually receiving a transplant is a long path. Mm-hmm. You have to have access to healthcare. You have to have someone who recognizes it and then also recognizes the need to refer you to a specialist, like was mentioned before. Then the specialist, depending on where you live, may or may not be a part of a transplant center, especially if you live in some rural areas. Then that becomes another barrier, 2 or 3 hours to a transplant center. Then the transplant evaluation process is not an easy one. It's probably one of the most complicated processes we go through in the medical system. And so then there are the barriers of distance, time, money, needing a partner in healthcare who doesn't have to go to work. And so I think that there are a number of reasons that minorities and people who are financially challenged are underrepresented on the transplant list. So I guess the short answer is no, they are not African Americans breaking down the doors of the transplant centers. I think that there are not as many as should be seen. I go back to still prevention is the key. I think that what you've been talking about the whole time, being identified, being treated, so you never need a transplant is still number one. But if you are at the place where you have end-stage liver disease or you have liver cancer, then everyone should have a space at the table and everyone should be given an equal chance to getting that treatment modality.
So let's say someone thinks that they should be considered for a liver transplant or their loved one should. What exactly should they do? How can they advocate for that to make sure that they aren't one of those people who should have come under your care or our colleagues on this panel care and didn't?
So I think there's a couple of different ways. First, there's no better advocate for you than you or your family member. So the first person to speak to is your provider and say, am I a transplant candidate? Should I be referred for a liver transplant? And then I think even beyond that, if you're not getting the answers that you want to get, then call the transplant center directly. We get those calls every day. And I think that one benefit of us living in a more digital world, with Google, you can search what is the closest transplant center to my zip code. And whether that be Duke or New York Presbyterian or UCLA, you call that transplant center. All the transplant programs have websites with a 1-800-liver or whatever, call and say, I think I need a transplant. Some of them even have online registrations where you can put information in and someone will call you back. But I think the key is why we're here today is education. Many people don't even know transplant's an option. They don't know that they would be a candidate, or they make an assumption that they wouldn't be a candidate because why didn't someone mention that to me? And so I think that, we have to teach people not only to prevent, but to advocate. You have to be your own healthcare advocate.
Yeah, I think that's definitely the message. Our healthcare system is very complex. So asking those questions, knowing how to ask those questions, bringing someone with you really will help people navigate that. Dr. Dove, thank you so much for sharing all of that knowledge. We did receive a number of questions when our guests registered for this webinar, and I want to just use some of our time at the end to get to questions that we haven't already covered. We did already cover, by the way, a lot of the questions that came in. And Reverend Dr. Dowdy, I'm going to bring you in now. One of the questions is, how can faith communities incorporate this information, like what we shared here today, into their existing programs?
Well, every local congregation is different. There are some that have health ministries, and certainly they can utilize those health ministries and they can reach out to their local communities. They can reach out to their local hepatologists, and also they can, pastors can utilize sermons as a way of educating people and, inserting. And that's one of the things that we did is we actually found scriptures that dealt with healthcare, and being able to identify those scriptures to go along with why it is important and what God thinks about healthcare. And in this case, we're talking about, the liver, and it does regenerate, which is good news. But taking the assets that you have, go to our website, look at the information that we have. There's a ton of information that's available with the Duke Hill Amazon partnership. But I think coming to the table and also having the researchers come to them, they can reach out to organizations that are closer to them. And I think that's a good start.
That's perfect. Dr. Dove, back at you. This came from an advanced practice provider who registered for this webinar and asks, how can I support patients with new or existing diagnoses of liver disease, so particularly for APPs?
I think APPs are a crucial part of the network. They're a big part of our practice here in the Transplant Center, and they're a big part of the community. I think that healthcare is a partnership in general. And as people develop signs of end-stage liver disease, it's often an ongoing titration of medications. There's a lot of education about, what you should be eating and what you should not be eating. Should it be low sodium? Should your medicines go up this week, down this week? There's a lot of symptoms. And I think that AP, in this very busy medical climate where there are probably not enough providers in general, APPs who are well-versed in liver disease are, crucial. So I think the APP should know also if she's or he is working within primary care, who are the people they can reach out to? Who are the gastroenterologists and hepatologists who know a lot about liver disease, who are willing to take their call if they have questions, who are willing to act as they can be a referring base to those people. So I think that they're from beginning to end, from education to treatment to referring. APPs are sort of part of the entire process.
Awesome. And another question for you, Dr. Dove. How long is the list for a liver transplant approximately?
So the list is a constantly moving target. So at any one time, there could be, as many as 25,000 people on the list, and then 10,000 are coming off and another 10,000 are going on. So, but I think for liver, people really concentrate on the number of people on the list, which is not quite as important for liver as it is for kidney, where when you get your kidney transplant is a lot of that's dependent on time. So where you are on the list. Or livers are given out, organs are distributed based on how sick you are. And how sick you are is determined by a number of factors, including some of your blood tests. And then we calculate this number that estimates how sick you are. And so the goal is for the sickest person to go first. So there are people who've been on that transplant list for one day who go before someone who's been on that list for 6 months, because the numbers say that they are sicker, and if we don't transplant them sooner, that they could die from liver failure. So yes, the list is long and you can wait. That's why we, are big advocates for considering living donor if that's an option for you. But I think there's a lot to learn about that process.
Dr. Wilder, there's a couple questions that came in about alcohol, and if you can answer briefly, can the liver damage from alcohol be reversed, and how can it be reversed, and are some alcoholic beverages better or safer than others?
Okay, great questions. So absolutely. So one of the leading causes of chronic liver disease in the United States, in fact, the leading cause and often cause resulting in liver transplantation, is alcoholic liver disease. And we, as liver doctors, every day see the damage related to alcohol in the liver. In fact, that's actually been something that has arisen, particularly here post-COVID in our clinics. The good thing is that the liver can regenerate, that the damage and the inflammation, that's the real problem with alcohol that occurs, can improve. And I've seen many patients of mine do really well. I'm talking people who are very sick, but when they stop drinking alcohol, and actually live a healthy life, exercise, fresh fruits, fresh vegetables, they actually can do quite well in the setting of alcohol cessation. Now, in terms of different types of alcohol, while we know that different types of alcohol, like your sort of hard alcohols, your bourbons and vodka, have sort of higher concentrations per, the actual ounce, what's really important is the amount that you're drinking. Because regardless of the alcohol content, it's really the number of drinks and the servings that you need to be very aware of in terms of the burden of alcoholic liver disease. And we're talking to our patients, particularly in men, we're saying healthy. Honestly, I never recommend drinking every day. And if you are going to be drinking, particularly if you're drinking multiple times a week, I always say if you're a male, drinking more than 2 drinks at a time is probably going to be putting you at greater risk of alcohol related liver disease. And for females, drinking more than 1 drink in a setting is going to put you at greater risk of alcoholic liver disease. Depending upon what you look up online, you maybe see more sort of conservative, more liberal suggestions. But I see so much of alcoholic liver disease, people who don't realize, the burden it is and the impact it's having on the liver. And so that's usually my recommendation for my patients.
Yeah, it takes a lot less than people think. So thank
Yeah.
you for sharing those numbers. Dr. Span, what are the earliest signs of liver disease? If you are going to have symptoms of liver disease, what might they look like? And then if you can just round out generally preventing or managing or halting disease, liver disease, broadly speaking.
Yeah, absolutely. So, as we mentioned, liver disease, you don't really have a lot of symptoms at all until you start to experience signs of liver failure. And that can look like a couple different ways that we think about. One could be you could start developing swelling in your abdomen, and that could be related to fluid buildup in your abdomen as a result of your liver failing. We can also see patients develop something we call jaundice, which is yellowing of the skin. And in Black patients, particularly, you want to look in their eyes, or the whites of your eyes can start to look yellow. And that's a sign of the liver experiencing some damage as well, too. Sometimes people can develop some confusion related to liver disease, and that's not necessarily something that's easy to identify, but if people start having difficulty with recognizing the people who are around them, and they are normally able to do that, or are able to recognize how to use things that they would normally be able to do, for example, how to use a fork, how to use a spoon, how to use their phone when normally they would be able to do that. And if that's something that waxes and wanes and changes over time, that could be a sign of liver disease as well. But all those are things that are signs of advanced liver disease. Early liver disease, still difficult to identify. You may experience some symptoms of tiredness and fatigue as well, related to that too. And so those will be kind of the focus of what I would say as far as potential signs of liver disease. And overall, as far as prevention goes, you want to ensure the things that we've discussed here today, focusing on whatever is causing that inflammation to begin with, and trying to stop that early and often as best as we can.
Awesome. So we're going to do a rapid fire round out of our discussion, and really ending with where we started, which is liver health for communities of faith, and how we as community members can ensure that everyone has access to great information and equal opportunity to receive the highest level of care for liver disease. So I'm just going to go around the panel. Reverend Dr. Dowdy, give me your one quick takeaway of what you think might resonate with your own congregation.
Well, one, there's hope for someone that has liver disease. And it was very informative to hear Dr. Dove talk about it's how sick you are. It's not how long you've been on the wait list, but how sick you are. And the liver does regenerate. And I think that that's very good news for them to hear. They just have to get checked.
Right. Dr. Wilder?
Yeah, building off what Reverend Dr. Dowdy said, it's important that you make sure that your primary care doctor is checking your liver tests in doing the proper screenings for you. And if there is any concern about your liver identified, please make sure you get referred to a liver doctor so you can get the proper care.
Dr. Span?
Yes, absolutely. A lot of the risk factors that are associated with MASLD in particular are things that are commonly found in the Black population: diabetes, hypertension, high cholesterol, all of these things that can be preventable. And if we can prevent those diseases, we can also prevent MASLD as well. So my focus would be on that.
Dr. Dove?
I think that prevention is key, and being your own healthcare advocate is key.
Fantastic. Thank you all for helping us understand liver health, and for talking about two common conditions that impact the Black community, and how we can partner with faith communities to ensure everyone has up-to-date, reliable information. A very special thank you to Reverend Dr. Dowdy for bringing in your critical perspective. And for those watching, please talk to your doctors and other healthcare professionals to ensure you are discussing how to get screened for liver diseases and how to get treated if you do have a liver disease. To find out more about ABGH, find us at blackandgastro.org or on social media at blackandgastro. This recording will be available soon on our website. Finally, ABGH has a lot planned to continue this conversation in our community. Our network of Black doctors is growing, and we are excited to bring you more. Follow us and stay tuned for our next event.